Starting the recording.
Okay.
Great. Sir, with your permission, I would like to start now.
Okay. Yeah, please.
Great. Thank you, sir. So good evening, everybody, for joining this webinar. I am Dr. Amit Borse. I am marketing head for IVA, a division of MCure Pharmaceuticals in India. IVA is on a mission to nurture and support 28 days. Programming 28 is our scientific theme for the year, and it is based on the concept of managing an ovarian cycle with different gonadotropins, analogs, and hormones. Materna is a focused brand and is an epitome of quality and success. We are very happy and we are very thankful to host this event. The event was conceptualized by Dr. Rajan Vaidya himself, and it is called International Icons of IVF. This time we have a theme of oocyte banking. Before I take this forward, I would like to introduce our host, Dr. Rajan Vaidya sir. He's honorary consultant, Department of Assisted Reproduction, Nauroz Jivadia, IVF Center, Parel, Mumbai. He's in national and international faculty at ART conferences. He has his own center with the name of Ankur Fertility and Endoscopy Center, Kalyan, and Venkatesh Hospital and Nursing Home, Kalyan.
It's okay.
Yeah. So he does not require any introduction, my dear friends, but yes, there's a protocol to be followed. We also have today with us our co-host, Dr. Meenakshi Chaudhary ma'am. She is a senior consultant in reproductive medicine, Newcastle Fertility Center at Life Newcastle Hospital, NHS Trust, UK. She leads the mitochondrial and egg donation program over there and works as a research lead as UK regulatory body HFEA person responsible. Other affiliations are Newcastle University, Wellcome Trust Center of Mitochondrial Research, Trustee Sperm Egg Embryo Donation, UK National Charity, Founding Director for Fertility International. As her academic brief says, she is overseeing multi-million several funded research grant projects, recognized UK and internationally invited speaker with talks given in Europe, USA, Asia, and worldwide. Several high-ranking publications with nearly 10 since 2020. Served on several UK national executive committees, selected as top 5 Asian women of achievement UK Awards 2020. So I welcome Dr. Rajan Vaidya sir and Dr. Meenakshi Chaudhary ma'am for this session. And I welcome Dr. Shaileja Nair ma'am as well. May I now hand over session to Dr. Rajan Vaidya sir, please.
Amit, my screen is lost.
So you can just minimize whatever is visible on your screen right now.
Yeah, correct.
Absolutely.
Thanks for the kind introduction, Dr. Amit. And this is the second of our series of academic webinars, which I have conceptualized as with the interactions with the international icons of IVF. So good morning, good afternoon, and good evening to all our viewers and participants all around the world. I welcome all of you to the second of this series of academic webinars. Dr. Shaileja Nair, our speaker today, is a Deputy Medical Director at London Egg Bank, London, and will be our speaker for today. Dr. Meenakshi Chaudhary, already introduced, a senior consultant in reproductive medicine, Newcastle Fertility Center, UK, will be my co-host. Welcome, Dr. Meenakshi as well, and Dr. Shaileja as well. Dr. Shaileja will be speaking to us, as we all know, factors predicting clinical outcomes from 494 vitrified oocyte donation cycles at a UK regulated egg bank. I am glad to let everyone know that myself and Dr. Shaileja have been batchmates throughout our graduation and post-graduation days at Lokmanya Tilak Municipal Medical College, Mumbai. After MD, she worked as a senior registrar at All India Institute of Medical Sciences, New Delhi, and then as an associate professor in obstetrics and gynecology at Maulana Azad Medical College, New Delhi for 8 years. Since 1998, she has been working in the United Kingdom in the field of infertility. In 2004, she became the Deputy Medical Director at the London Women's Clinic, Harley Street, London. Currently, she is a Deputy Medical Director at the London Egg Bank which is an integral part or integral to the London Women's Clinic. I know Dr. Shailaja has a long CV to follow, but she has strictly told me to restrict up to him this much only. So with your permission, Dr. Shailaja, I now hand it over to Dr. Meenakshi. Just introduce our topic for today and take over the meeting further, and before you hand it over to Shailaja.
Thank you. Thank you, Dr. Vaidya and Dr. Bose for the introduction. And welcome, Dr. Shailaja Nair, for accepting this kind invite from Dr. Vaidya. And it's my pleasure to introduce the topic of oocyte banking and oocyte donation. So if you remember, the first talk of this series was about mitochondrial donation, which would not have been possible without women coming forward to donate eggs. So it's a very important topic, which Dr. Shailaja Nair would be talking about today. If we look at it, women, when they consider oocyte freezing or oocyte banking, as commonly referred to as well, consider banking their eggs or oocytes for three different reasons. One indication is reproductive need, that is someone going through cancer treatment or other kind of medical conditions, which may render them going through premature infertility, would be considering freezing. So that is reproductive need. The second is reproductive choice. That is women who make a decision to donate their eggs for banking purposes, not donate, but freeze their eggs for banking purposes for their own use, which is commonly referred to as social egg freezing. And the third one is reproductive gift, where women who do not need the eggs for themselves at this present moment of time, but want to donate it for use by other women to help other women, couples to have babies. That is the oocyte donation. And oocyte banking gives the flexibility for that. So this is the theme of today's topic. And I hand over to Dr. Shailaja Nair to talk about this very important aspects, as well as to cover what all practical tips and tricks we need to know to increase the success and optimize the success in this field. Before I hand over, I would just like to remind all the listeners that any questions you would like to ask Shailaja ma'am at the end of this presentation, please type it in the chat box in the Q&A session, and we will address it later on. Thank you for listening, and over to you, Shailaja ma'am.
Thank you. Thank you very much, Meenakshi. I'm going to try and attempt to share the screen. Yeah, is that okay? Can you
Yes,
hear?
absolutely.
Yeah. So I just want to introduce my clinic, and of course, Rajan has been very kind to introduce me. And I, of course, thank the organizers for giving me this chance to be here this afternoon. And for Meenakshi, Dr. Meenakshi, to also be here as a co-host. We enjoyed your talk immensely the last meeting. My meeting may not be as scientifically challenging to those who are here today, but I hope it will give some overview of what we do at the London Egg Bank. And the London Egg Bank is a subsidiary, as Dr. Vaidya said, of the London Women's Clinic, which is a large fertility center. But within the London Egg Bank, we deal with egg donors, egg recipients, and social egg freezers. So my intention today, the talk today, is to give you some idea of what we do with specifically to highlight some of the variables, whether it's donor, recipient, embryology variables that could affect the chance of success. I mean, it's only, of course, cannot give you all the details because it's a large subject, but I hope it'll cover some of the points that that we have gained experience from within this egg bank. So if you look at the HFVA data, the number of egg donation cycles in the UK has doubled from 2000 in 2008 to 4,000 in 2016. And the numbers are only increasing since then. And this success rate is driven entirely, almost entirely, by the technology of vitrification. So using vitrified warm eggs has dramatically increased the success rate as compared with slow frozen donor oocytes. And this is simply the biggest driving force, both in egg donation, the frozen donor egg banks, as social egg freezing, as Dr. Meenakshi said, and the other options that now are available to women who want to preserve their fertility for any reason, medical or social. And it is through that success of vitrification that the London Egg Bank since 2016 runs entirely 100% using frozen eggs only. So it's a purely frozen cryo bank for donor eggs. So if you look at our own progress, we started freezing eggs in 2014. I'll give you some of the data that we have from our center. Prior to 2014, we did only fresh egg donation. And there was a period of time between 2014 and 2016 that gradually our experience with vitrification increased and the number of fresh donation cycles decreased. And again, since 2016, we no longer offer fresh egg donation. So if you look at our egg donors, what are the kind of women we attract to be egg donors? They are UK residents, and in fact, most of them have university degrees. So they're educated young women who decide altruistically to volunteer to dedicate other women who need eggs. They're healthy women, and the UK HFEA requirements dictate that they must be between 18 to 35 years of age. They're screened for ovarian reserve. They have normal ovarian reserve. And the other screening, counseling, and recruitment is done in accordance with the HFEA code of practice. So donors have assessment when they volunteer to become egg donors. Besides a general health screening, they are tested for they're screened for ovarian reserve, primarily the antral follicular count and the AMH. They also have, of course, general medical and family history for hereditary diseases, and have screening for infectious diseases, genetic diseases. All donors are offered implications counseling as mandatory. And if you look at what is the standard protocol, what do we offer these young donors when they come to donate their eggs? Ovarian stimulation is the standard protocol is using recombinant FSH injections from day 2 or day 3 of the period. The dose of FSH depends on those ovarian reserve assessments, anti-Mullerian hormone, antral follicular count, and BMI. They're all on the antagonist protocol, universally on the antagonist protocol, where we start either cetrotide or pyramidel on day 6 of the stimulation, or when the lead follicle is 14 millimeter or more. And the standard trigger, which we administer 36 hours before egg collection, is the analog, the GnRH analog. We tend to give buserelin 0.5 ml, 36 hours before egg collection, which is done under sedation. So once the eggs are collected, they are denuded in hyaluronidase immediately after egg retrieval. And all mature eggs are added to Vitrolife medium and subjected to a 2-step process of equilibrium and vitrification. And the vitrified eggs or oocytes are loaded on cryotop and plunged into liquid nitrogen, and then stored in these tanks, which are monitored 24 hours a day, 7 days a week. So that is protocol. And we have recipients who also come to the London Egg Bank. The commonest indication for needing donor eggs, of coming to the clinic requesting treatment using donor eggs, happens to be advanced maternal age, previous failed autologous treatment attempts, and reduced ovarian reserve. The risk of transmitting a genetic condition is a cause, though they are less commonly seen at our center. We're increasingly getting male same-sex couples or even single men, who are requiring donor eggs and surrogacy. So that's kind of the background. And recipients also need assessment. They have a general health assessment. The reason for treatment is documented. Their BMI is documented. And their male partner has a general history, and specifically we check for the age and the semen parameters. Recipients again have various screening tests. The pelvic ultrasound scan, of course, is very important. We are also looking at the endometrial cavity. We do not routinely ask for endometrial cavity assessment other than a pelvic ultrasound scan, but in a select group where we think there is a suspicion of an endometrial polyp or a submucous fibroid, further tests like aqua scan or hysteroscopy would be advised. And recipients also it is mandatory to offer implications and support counseling. So recipients for endometrial preparation are given between 6 to 10 milligram. That's kind of standard of oral estrogen tablets. We give Proguanova in the UK. And the aim is to achieve an endometrial thickness of 7 millimeter or more with a triple pattern. So there I have ultrasound monitoring, and occasionally may need supplemental estradiol patches, 100 or 200 microgram every 2 to 3 days, depending on the endometrial thickness and texture on the monitoring scan. So it usually takes between 10 and 12 days of oral estrogen tablets in the vast majority of recipient women to receive, to get to that target endometrial thickness and texture. So once the endometrium response has been achieved, the next step would be to plan to thaw the eggs. And is on the day that the egg thaw is planned, that recipients are advised to start progesterone. And the standard protocol is progesterone pessaries, cyclogest is commonly used, 400 milligram, or utrogestin, 200 milligram, 3 to 4 times a day. As our current protocol at the present time, we do a progesterone check, a blood test for serum progesterone on the day of embryo transfer. And we aim to get the P4 to be 50 nanomoles per liter or more. And if it is lower, we do add injections, either intramuscular Prontigest or subcut Lubion injections. So once those eggs, the eggs then are allocated mainly in cohorts. So they're frozen in usually straws of 3, 4, 3, or 2. And they're allocated in cohorts usually of 6, 8, or 10. And then after so they're warmed then in decreasing concentrations of sucrose at 37 degrees, placed in the equilibrium culture medium, kept in mink incubators for 2 to 3 hours, following which ICSI is performed using either partner sperm or donor sperm. And all embryos are then cultured in the time-lapse system to the blastocyst stage or day 5, which is the day we would be aiming to do an elective single embryo transfer in the vast majority of women. All embryo transfers are carried out under transabdominal ultrasound guidance. A beta HCG is a blood test, is usually done 11 to 12 days after the embryo transfer, and a pregnancy scan arranged at 7 weeks if the test is positive. And medications are continued until 12 weeks of pregnancy, both the estrogen tablets and the progesterone. So here is a graph to tell you a little bit about our own experience since we first started freezing eggs in 2014. You would see that the thaw rate, the survival rate, has stayed consistently above 90% over the past 6 years. The fertilization rate has stayed between 70 to 80% over the last 6 years. But the blastocyst formation and the implantation rate has increased quite significantly after 2016, so the first 2 years, I said, we were gaining experience in egg vitrification, and that reflected a little bit in our implantation rate and our success rate. So you can see our implantation rate has gone up from 2014 and 15. It was relatively low to 36% in 2016, and has stayed above 40% since 2017. So which seems all right. And along with that, there's a growing percentage of patients who now have surplus embryos, frozen, good quality embryos, which are suitable to freeze after that first embryo transfer. And you can see again a steady increase in the number of recipient couples having a chance to have more than one attempt since 2017, which is good, which also means that the cumulative pregnancy rate would be far higher than the pregnancy rate after that first embryo transfer. And this is, again, it's all part of the same story, that since our success rates went up, our implantation went up, the number of double embryo transfers has declined. So now it's almost 90% of our embryo transfers or more are either elective or single embryo transfers. Either there's only one embryo, which means there's only one embryo to put back, or elective single embryo transfer, which it happens increasingly as our blastocyst formation has increased. So we know the lab is working well. We know the protocols are working well. We know the success has been fairly consistent. But of course, there are several factors. We're nowhere near 100%, obviously, whether it is the donor profile, the maternal factors, the paternal factors, lab conditions, and various other conditions that would finally result in the success of a treatment. And I think there are two studies that I would like to share today, where we looked at some of these factors that could affect the success rate. So one of these studies that I would like to talk today is about an analysis we did of all our recipient cycles, the first attempt only, not sibling or where they came back after a failed cycle, between 2014 and 2020. We did not include cumulative data, so it was only the first embryo transfer. And we also included data from those first 2 years when we did not do so well. So if you look at the number of cycles we studied, we looked at nearly 1,200 cycles, where we thought 9,400 oocytes, resulting in 6,800 or thereabouts embryos. We nearly had 4,000 good quality blastocysts, which was suitable for transfer or freezing, utilization, that is. And more than 1,400 have been transferred with more than 500 ongoing pregnancies and live births. So we looked at some of the characteristics. I won't go through all the details because I thought that might get overwhelming. And so one of the conditions, and this is very important as we look at our donor data, is the effect of egg donor age on the success rate. And what we've consistently seen is a reverse U-shaped curve in relation to donor age, meaning the best performing donors are between the ages of 22 to 30 years, with young donors younger than 22 and older donors older than 30 doing less well. And there are many, many studies that have shown that embryonic aneuploidy rates are actually higher in very young women. And this reflects in our own egg donor data. So this is something that we have taken into account as we allocate eggs and as we counsel our recipients about the number of eggs that they may need or their selection of their egg donor. We looked at the recipient age. Now, at our center, we do treat older recipients up to 54, actually, although the numbers above 50 are thankfully small. And we found, whatever reason, whether it's the blood flow, the endometrial blood flow, but there was a significant decrease in the success rate when you look at recipients below the age of 40 years, for example, and recipients above the age of 50 years. So there is certainly some effect of age. Again, there may be other confounders, which we cannot yet say for certain, but there did seem from this data a decreasing chance of implantation as the recipient's age advanced. We looked at the paternal age, and that seemed to also have some impact with where the partner was less than 40 years full. And if you compare that with partners who were 60 plus, which again, the numbers are fewer maybe, the implantation rate declined. One of the big influencing factors was and this has come up in our data more than once, is the surplus embryos as a predictor of outcome. So you can see that where we have more embryos that are suitable to freeze from one cohort of eggs, the chance of live birth or clinical pregnancy increased dramatically. So even with the same kind of embryo quality, the same type, grading of that blastocyst that we may have transferred, the live birth rate went up significantly if there were more than, say, if you compare with more than 5 blastocysts from that cohort of eggs. This reflects, of course, oocyte quality. It might reflect the lab conditions. It might be due to donor factors, donor stimulation factors, lab factors. But where we got good quality blastocysts, we got good quality eggs, which led to more transferable blastocysts and more embryos for freezing. The success of that first live success went up. And that again, we look then at how many eggs should we then be allocating? What is the optimal number of eggs that a recipient might prefer to reserve or to get? So when we looked at our data, and this is the data of 6 eggs, 8 eggs, and 10 eggs. So the survival is the same. The fertilization rate is the same. The blastocyst utilization is the same, but the implantation was higher in, say, recipients who received 6 eggs versus recipients who received 10 eggs, because there was probably higher, obviously, number of chance of selection, a larger number of blastocysts available for that purpose. So when you look at the conclusions from this study, we found that the success rate seems to follow an inverse U-shaped curve in relation to the age of the donor. In univariate analysis, increasing recipient's age seems to inversely be associated with implantation. Advanced paternal age may be a confounder for blastocyst formation and pregnancy, but further tests are needed. And we haven't also got to look a little bit more into the miscarriage rates. One of the strongest predictors is surplus embryos that are available on a particular cycle, meaning the higher the number of embryos that are available to freeze, or the higher number of surplus embryos that are available from that first cohort of eggs, the higher the chance of live birth at that first attempt. So that is one study. And I want to now share another study that we did, which was basically looking at a 2-year pool. We looked at nearly 500 vitrified oocyte donation cycles at the London Egg Bank. It was a retrospective study looking at the 2-year from from January 2017 to December 2019. And we looked at nearly 500 altruistic consecutive oocyte donors donating for the first time. And we also looked at 599 consecutive recipient cycles, which were matched with 340 egg donors. So we looked at this cohort to see whether we could learn something about what could affect the chance of pregnancy. So we looked at 2 things. Now, if you look at our donor pool, the median AMH from these, the cohort we studied, the median AMH was 26.7 picomoles per liter. The median antral follicular count was 26. The majority were nulliparous, nulligravid. The median BMI was 22.9. The age, 26 years. The average or the median number of eggs we collected, total eggs was 19, and the total number of mature eggs, 14. So that was the kind of briefly the data from this pool. And what we looked at is, when it came to the donor outcomes, was 2 factors. What was the total number of oocytes collected, and what was the total number of mature oocytes collected? So what were the donor parameters or donor variables that could influence donor, the oocyte, pool? And I just want to home into two of the big factors that we found out of the many that may not have been so significant. One is the age of the donor. So this is not the success rate, but the number of total oocytes and total mature oocytes collected. And you can find that as donors were older, donors that were older, above 30 years, produced less number of total oocytes and less number of mature oocytes as compared with younger donors, even with the same AMH and antral follicular count. And I'll go through that again. And if you look at the AMH, there was an increase in the number as expected, number of eggs, total number of eggs collected, and total number of mature eggs collected. As the AMH went up, the response to stimulation was higher, but there was a plateau effect. So after the AMH was above 40 picomoles per liter, further increase in AMH did not result in increase in the number of oocytes collected, or indeed the total number of mature oocytes collected. So there was a consistent increase in the response to stimulation as the AMH increased, but there was no further increase after the AMH was 40 picomoles per liter or higher. And then when we compare the two, we looked at both AMH and age together. You'll see that where the AMH was below 15, there was a lower number of eggs and lower number of mature eggs collected from donors who were between 30 to 35 years. And again, in donor with the same kind of response or the same pattern in where the AMH was between 15 to 29.9. But where the AMH was above 30, the age difference seemed to decrease. So you find a similar number of eggs were collected in donors of all the three age groups. So where older donors had a very good ovarian reserve, they responded quite well to stimulation. And again, you see that plateau effect that after the AMH went above 40 picomoles per liter, there was no further increase in the number of eggs collected or the number of total mature eggs collected in all those three age groups. So the conclusions from this particular trial was that the AMH was a very good predictor of both total oocyte and total mature total oocyte number. Again, that there was a plateau effect after that AMH was, it was higher than 40 picomoles per liter. The antral follicular count was a significant predictor of total mature oocytes, but not of total oocytes. So there were more immature eggs from smaller follicles when we measure the antral follicular count between 2 to 8 millimeters at the baseline scan. And donors who are aged between 30 to 35 years had a significantly lower number of total eggs and total mature eggs than donors aged between 18 to 24 years, even when their AMH level was the same. So that was the first conclusion. So this comes somewhere. So if you look at the recipient pool from this second study, the median age was 44 years, the BMI was 24.4. Some of them had been pregnant, but most of them were nulliparous. And so those who had, say, one or more miscarriages were 37%, and about 5% had more than 3 miscarriages. And about nearly half of their partners were younger than 41 years. So that was the recipient pool from that second study. And they have received an average of 7 eggs with 100% survival as a median, with good fertilization. And 38% of the oocytes received resulted in transferable embryos. 57% of the oocytes fertilized, or you might say embryos generated, resulted in transferable embryos. This is the pool of those 511 recipients that we included in our study. And 87.2% had a single embryo transfer, with 76% having elective single embryo transfer. So 800 blastocysts was replaced from this pool. And we found that the implantation rate per embryo, that is, was 40.6, with clinical pregnancy rate per embryo transfer being nearly 50%, and the live birth rate about 37.9, with 267 deliveries so far. But you can see 95.5% were singleton pregnancies. And you can also see that there are 802 blastocysts still remaining in storage, which means that this pool of 511 recipients, many of them are likely to have more pregnancies using those blastocysts, and the cumulative pregnancy rate again could be higher. So we looked at what affects the recipient outcome, and again, this slide is a little crowded, but it reflects the previous trial, that there is an inverse U-shaped curve relating to donor age. And if you look at the success at 23 to 29 as the reference group, the success clinical pregnancy rate and the live birth rate was lower in donors aged 18 to 22 years, and also donors aged 30 to 35 years. And when we looked at the other parameters, if you look at one of the biggest factors, again reflecting our first study, is the rate of transferable embryos per oocytes received and the rate of transferable embryos per oocytes fertilized. There's a big difference in the success rate. If you look at the adjusted odds ratio, the p-value, that really gave us the pregnancy rate, the clinical pregnancy rate, and the live birth rate was much higher when the rate of transferable embryos per oocytes received and oocytes fertilized was higher, both with the clinical pregnancy and the live birth. We looked at the recipient BMI, and in this particular group, the recipient with a higher BMI and history of previous miscarriages had a lower chance of clinical pregnancy. There may be other variants, but this is this particular group. So when we came to this particular group, we found that the selection of the youngest possible donor is really not necessary to improve the chance of success, and it can actually reduce the chance by going to a very young donor. It appeared there may be other confounders that raised recipient BMI may reduce the chance of success. And again, the high rate of transferable embryos from oocytes received increase the chance of success, and high rate of transferable embryos from oocytes fertilized increase the chance of success. So this is where we think donor selection, the management of donor stimulation, the timing of trigger, the lab conditions, all of this must influence the chance of success in a big way. And therefore, now to conclude, the vitrification is indeed the gold standard for oocyte cryopreservation due to its reliability and efficiency. And as Dr. Meenakshi started this session, egg freezing is becoming popular for women seeking fertility preservation. Of course, we have less data from this particular cohort of women, since they are not looking to get pregnant in the short term, and they're looking to preserve for the future, and they may be older than are the women typical average, egg donor. But vitrification is giving women a chance to preserve their fertility. At the London Women's Clinic, at the London Egg Bank, we do about 400 egg freezing cycles. So that, of course, is a separate matter. But more importantly, egg banks allow recipients to rely less on fresh eggs. They don't need to go with synchronization. They gives them increased choice, increased convenience with excellent success rate, and avoids the need to travel overseas or cross treatment cycles, which are no longer needed. So thank you very much. I will stop sharing. If you have any questions. That I think probably hopefully given you an overview.
That was a very nice, excellent talk, Shailaja, as expected. You covered the topic very, very comprehensively, and almost all aspects touched wonderfully, very, very well. Very importantly, the data came out from your own practice, so that has a lot of meaning attached to it. Dr. Meenakshi, do we have any questions?
Hello, thank you so much, Shailaja, for a brilliant presentation. I would agree with Dr. Vaidya. That was really, really interesting. At present, there is no questions asked in the Q&A box, but I can start off with your permission, Dr. Vaidya.
Yeah, sure, please.
Thank you.
Go ahead. Yeah.
So Shailaja, it's excellent presentation. I just wanted to know, when you mentioned that for oocyte donation, when you freeze the eggs for women, uh, you have calculated the data as 6, 8, 10 oocytes, like you've grouped them into cohorts. So do you have a threshold of how many oocytes minimum you would provide a recipient? Or it depends on whatever number of oocytes are frozen for a particular donor, all of them will go to one recipient?
No. So the minimum number of eggs is 6. So 6 is the minimum. Yeah. If you see from our second, the data, the median number of eggs recipients received was 7. So there are. So we do have, though, because we have we donors don't produce in multiples of 6 or 4 or 10. There are, of course, going to be odd number of eggs that some recipients receive. And where we have eggs, very small number, like 4 left over, we do pool them with another. So sometimes recipients may select 2 donors, 4 from one donor and 6, say, from another donor. So if they're not, worried about having sibling embryos in the true sense, they do sometimes, link, add 2 eggs from 2 different donors on one cycle.
Right.
One question from my side. Yeah, Meenakshi, you have one more question. You can go ahead.
No. You can start off. There is some question asked in the question Q&A box as well, but I'll let you ask your question.
That should be taken first. Yeah, that should be taken first. Let us take up that.
Okay, so how long should we wait after denudation before vitrification? That's the question asked.
It's immediate. The denudation is immediate. And then, of course, they go through a 2-step process. But remember, vitrification is a flash freezing. It's not like the slow process. And while I'm not an embryologist and may not be able to give you the details in minutes, this is a fast freezing process. So it goes through, denudation is immediate. So we know how many mature eggs are obtained soon after egg collection. They go through those 2-step process in the Vitrolife media, and then are very quickly, loaded and vitrified. Once they're vitrified, they're loaded and then kept in these minus 180 nitrogen tanks.
Thank you. There is another question. I will take the liberty to ask that in the chat group.
Yes.
What is the pregnancy and live birth rates from donors above 35 years? So I know the UK regulation says that altruistic donors should be 35 or under, but sometimes there will be known donors who will be about 35. And maybe in India, they may be having donors who are over 35. So what are the chances of a pregnancy for these?
Well, actually, to be honest, we don't freeze eggs above 35 for egg donation. So where we have known egg donors, they tend to go for fresh egg donation because they are by definition known, and we are happy then to synchronize your cycles. So we don't have data with using vitrified eggs from older women at the present time. So with older women, well, the success rates are similar to our IVF patients in older women. So vitrification probably is not going to make a difference.
And Meenakshi, in India also we don't have donors more than 35 years of age. We restrict to the ICMR guidelines, which are around donors by default to be less than 35 years of age. Just to add to your this question,
Thank you. Rajan, you wanted to ask a question. You can go ahead.
Wonderful presentation, Shailaja. Again, 1 or 2 questions that came to my mind as I was listening to your wonderful talk is you said the surplus embryos, number of surplus embryos was a predictor of successful outcome. The more the surplus embryos, the more the outcome. I was thinking that it could be the reflective of the sperm quality, the number of embryos being formed more also may mean that the sperm quality was good, and that could also have a bearing on the outcome as an indirect indicator of the sperm quality.
Yes, absolutely. Of course, we have to do ICSI because the eggs are stripped and only mature eggs can be frozen.
Right.
So ICSI is done to fertilize all frozen thawed eggs. But there are confounders, and whether it's the paternal age or the semen parameters, we cannot tell. And I just want to share a little bit that there are 4% of our cycles, 4%, where no blastocyst is available for transfer. So we have found that in 96% of our recipients, we have at least one embryo. But in that pool of 4% of donors where we got no blastocysts, those eggs, when used with another recipient, with another sperm, another male factor, another couple, gave us comparable pregnancy rate. Yeah.
Wow.
But having said that, those where we had no blastocyst transfer and the recipient couple who had no embryos selected another donor, they also did well. So we couldn't really put it to a male or egg factor. And it seemed to be one of those factors that still remain in that unexplained category.
Wonderful.
It's frustrating, nice. But we do get what 4%.
Right.
And we cannot explain why.
I think there's some question, Meenakshi, coming up.
Yes, yeah. So there is one question. What do you think is the role of oocyte activation with calcium in frozen oocyte thaw cycles? Thank you.
Well, we have used oocyte activation where we think the embryo egg quality is poor, but of course it would not be. That is just usually for our IVF patients where we've had poor fertilization, but it is not something again that we would look at this particular cohort of women egg donors. So we don't do oocyte activation for egg donors or for frozen eggs. We've done that with our not routinely but selectively, and have found success rates which are good, but don't have data for that right at this present time.
Yeah, I mean there are different indications for oocyte activation, isn't it? Freezing of oocytes may not be one of that for everyone. There is another question coming up. What is the cost difference between fresh and frozen oocyte cycles in your center?
The cost?
Yes.
I have to admit, I don't know. I mean, we know we have various packages, but these things change, and I have to freely say that it could be on our London Women's Clinic or the Egg Bank website, but I'm not an expert at all in cost, and I cannot comment on this.
Okay, that's fine. Right, another. Sorry, I was just going to say another question, which is there, not visible in the Q&A session, but asked in the other chat function is bridging technique preferred for vitrification of oocytes over the conventional method?
Can you repeat that for me?
Is bridging technique preferred for vitrification of oocytes over the conventional method? So the person asking, Anjana, hasn't specified what she means by this question. But
well, actually, this is an embryology question, perhaps, but I don't know really about the bridging technique. So as a clinician, I would say that this is not particularly,
correct.
I would have to ask my lab manager to answer that question.
Yeah,
that's fine. Rajan, you had another question to ask?
Shailaja, as a clinician, I would say, how long you have been doing incubation under time lapse?
We've been doing a time lapse for maybe more like, it could be 10 years, but we have been doing for the last maybe 4 or 5 years only time lapse.
Do you think does it make a difference ultimately to the live birth rate, to the conventional incubation vis-a-vis time lapse incubation? Do you think that the embryo dynamics and the selection of embryo through time lapse ultimately translates into a higher live birth rate?
Yeah, I think at this present time we do only, so we cannot really compare success rate cycles with.
Yeah, but anyway, this was just to know from you.
At the time of selection, the division is taken into account. The cellular division is taken into account, and a similar appearing blastocyst, if may be selected over another blastocyst.
Okay, right.
Based on division, so we do take the time lapse data.
Wonderful.
Into consideration. Right now, we're doing it universally for recipient couples.
All the patients, right? Fine. Thanks.
Okay, Shailaja, another question, which I know the answer, but I will let you answer. So someone has asked, what's the maximum duration for keeping these frozen eggs? I mean, I know UK has got its specific regulations, but if you would like to answer, 10 years or more, they have asked.
I mean, for donor eggs is 10 years. For donor eggs is 10 years.
Yes, indeed. And so in UK, as we know that for fertility preservation, it could be more than 10 years, up to 55 years of storage. But there is now a petition going on to see if the law can be changed even for donor eggs in near future. But at present, it is 10 years, as you rightly said. I can't see any other question, but if I could take the liberty of asking you, um, um, I have published recently in May 2021 in the Human Reproduction Journal on oocyte freezing and the national UK data, live birth outcomes. So how the success rate is comparable for live birth using frozen eggs compared to fresh cycles and frozen embryo transfer cycles. And it does show that the success rate is much lower with frozen oocytes compared to fresh eggs. But however, when we looked at donor versus autologous use of eggs, there was a vast difference. And definitely the donor eggs was good success rate as we would expect. The success rate was still with donor oocytes, with frozen oocytes, the national data. What I found was lower than fresh donor oocytes, but very like 4% difference was noted. So clinically, even though it was statistically significant, clinically, I don't think that would make a huge difference. So would you like to pass on any message for our viewers and listeners about own eggs frozen and the chance of a live birth? Because we don't want to give a incorrect message that the success rate would be as high as 40% for those women as well in passing
and
on
you can
the
remember this is
information.
a highly select group with the egg donors are not infertile women. They
Yes,
are
indeed.
healthy, young, altruistic volunteers with a good ovarian reserve, have been through various screening tests, are not, again, looking to have a baby themselves and simply looking to donate. So there is no really, this is not comparable with an infertile population. At this present time, vitrification is getting better, the technology is getting better. It is opening up avenues which women did not have in the past. But it is still not the magic answer, as Dr. Meenakshi said, for every situation. And if one has a choice between fresh and frozen eggs, perhaps fresh is better. But at the moment, looking at our recipient population, looking at the convenience, looking at the fact that there's a guaranteed number of eggs before they commence the cycle, which you cannot always do with fresh, there is a huge advantage of frozen egg banks, but these remain frozen donor egg banks. Social egg freezing is an option that women are taking, not as a matter of choice, but because they're not yet ready to have a baby right now. So no one is choosing frozen over fresh eggs at any point in time as a matter of choice. Now, we don't have data at the present time to compare fresh and frozen, because I said to you, since 2016, we have stopped using fresh eggs. So we cannot tell you our clinic data of, the two figures we cannot give you at this time.
Right, thank you. There is another useful question in the Q&A box. It's in relation to serology. So as we know, I mean, when I talk about quarantine, only I think about COVID-related quarantine, but for sperm donors, we always have quarantine and the serology is repeated. But for in egg donor cases, do you repeat the serology post-oocyte donation? And what is the minimum time interval from vitrification to warming?
So at the moment, we don't quarantine eggs. Yeah, because as long as fresh egg donation is available, is still licensed in this country, quarantining eggs may remain a bit on the gray end. We know that is where it will go, and this is what we will want to do. At the point where what we do is we do the serology, infection screening within 3 months of the baseline scan. It is repeated again, and NAT testing, not the standard conventional screening, but the NAT testing is tested either on the baseline scan or on the day of the egg collection. So we try to do that NAT testing as close as possible to the day of freezing. But donors do not return after the egg collection to do another test at the present time. It might change, but not at the present.
Thank you. I mean, we follow exactly the same. So we do the NAT PCR testing again during the time of the stimulation phase. So we have got time to get the results and cancel a cycle if required, if it turns positive. I think that we don't have much time, but I will just ask the last question from my end. It's regarding contraception. So basically, some of these donors would be on contraception. Now, my personal experience is, and I have presented it as well in some meetings, is that if a woman is on contraception, we don't stop their contraception, like LARC kind of contraception, if they have got a depot or an implant or a minor coil, or a copper coil, we don't remove that. If they are just on oral hormonal contraception, we stop that. So they continue with those methods. And we have seen that, especially with copper coil, not minor coil, but if they have a copper coil in presence, the success rate is lower and the number of oocyte recovery rate is much lower as well. What's your experience about contraceptive effect on oocyte donor cycle?
I mean, as you said, because these are fertile young women, contraception is crucially important because sometimes, an egg at the time of a collection can get out into the pouch and there's a risk of pregnancy. So often our donors have condoms, which is the very standard, contraception. Actually, we don't ask copper T to be removed at all the coils. So I think I'll have to look into that data a little bit more. We don't ask the Mirena coil or the copper T to be removed. We encourage condom use when, if they're not using any other contraception. We ask for all hormonal, that is the implant to be taken, taken out at this present time, and the pill to be stopped.
All right. Thank you so much. Thanks a lot for a brilliant session and a great moderation as well with the Q&A answers we received from you. I would like to thank everyone, but I would like to pass it on to Rajan and Amit for concluding the session, but we are very grateful for your presence for today's session. Thank you.
Thank you, Meenakshi. Wonderful. And thank you, Shailaja. Wonderful talk again. Thanks a lot for accepting our invitation.
You're always a generous man. You're always a generous man. But I'm taking you literally, but your generosity has shows.
Thanks a lot. Yeah. We all enjoyed your talk a lot, and I have already texted Amit. This is a wonderful talk, and we must pass on the link to all the groups. So fantastic talk, and Meenakshi also handled the Q&A session very well. Thank you, Dr. Amit and the team MQR for taking further this purely academic series of webinars for the benefit of young and aspiring IVF consultants, particularly in the times of COVID, when the interactions for the international conferences has been restricted because of movement restrictions. I thought I would let us give the knowledge to their doorstep and they would benefit from it. So thank you everybody for making this session very successful.
Thank you.
And see you all again.
Thank you very much. Thank you, Meenakshi and Amit, Dr. Thank you. And Rajan.
Thank you everyone for this fantastic session, ma'am. What a brilliant session. And it is turning every time a much better version. And I really believe that after doing 300 and 400 of webinars nationally, this is a thing to be looking forward to. People are looking forward to this, all young and all the veterans as well. So in the participants, we have many veterans who are listening to this session. And we are thankful to Shailaja ma'am for this session, and Meenakshi ma'am, as always, you are fantastic. Dr. Rajan Vaidya is our mentor, and we would love to continue this initiative hereafter. We'll soon announce the next international icons of IVF, which will be announced soon. Thank you so much, sir. Thank you to everybody.
Thank you very much. Thank you.
Thank you. See you, Shailaja.
Bye. See you all.
Bye. See you for now.